will be talking a little bit about the management of BRAF and MEK inhibitor therapy. So I am not Tangela Butler. Unfortunately, she can be here with us today, but I will sort of go over this conversation. So these are my disclosures. Let's go to the next slide. So what is BRAF? So this is often in conversation I have with patients when I first see them. And it's something new to many patients. They're not used to hearing about mutations. And what BRAF is specifically in the context of melanoma is a driver mutation. And these are literally mutations that drive the cancers to grow. And oftentimes the cancers become addicted to this pathway and start to spread. So in melanoma, we see about half of patients having a BRAF mutation, especially in the metastatic setting. And when we talk about BRAF, we're talking about a specific part of the gene in what we sort of use as the address. We say V600E or V600K. So when you're looking at your pathology report, these are the things that we're interested in talking about. And why is that important is that we have drugs nowadays that block or target this protein or pathway and actually can cause the tumors to shrink or prevent them from coming back. So how do we test for this? There's actually been a refinement in the way that we test for these sort of mutations. It used to be that we would test only in the tumors that were either biopsied or removed. These would be generally something called a PCR test. And initially, we'd actually only just test for that BRAF V600E or V600K. And over time, we've developed newer testing platforms, something called next generation sequencing or NGS. And these platforms are preferred because we're now able to test not only those mutations, but hundreds of other potential genes and mutations that may be future targets or targets that you could be a part of a clinical trial. In rare instances, we can actually take the tumor that's been removed, put it on a slide, and the pathologist can actually look to see if, specifically to V600E, if that protein is overexpressed. And that's a relatively quick way to get a diagnosis. These other options that I mentioned before sometimes can take a week or more than a week to get a result back. So we usually use that immunohistochemistry for a quick way to find out. The newest way to test, especially for patients with more advanced disease, is to test your blood. So if you had a biopsy that didn't yield enough tissue for these tests to work, or we need a quick answer, sometimes we will draw your blood. This would be just a simple blood stick, and we're able to send it to other companies that can look for something called circulating tumor DNA. So what we found is that your tumor can actually shed DNA that can give us sort of a profile of the tumor and help us identify this mutation. And so similar to some of the next generation sequencing platforms, nowadays we're able to detect potentially hundreds of different genes and other features that may help us find treatment options for your melanoma. So you'll hear a bunch of different names, and these are kind of listed here, but these types of therapies are oral therapies, meaning they're pills that you take every day. There are both, we talked about BRAF and I'm talking about MEK, but essentially what we've discovered over the past decade or so is that if we target BRAF, we can do a good job of shrinking the tumors, but over time, we can develop resistance. So the addition of MEK, which is just another downstream pathway, the combination of those two drugs actually help improve the outcomes of patients compared to just taking a BRAF inhibitor alone. So what you see down here listed are both BRAF and MEK combinations, and I'll talk a little bit about these individually and kind of where they fit into sort of our treatment landscape. So when do we use these drugs? So there's two general settings that we think about when we see a patient about using or offering these therapies. So one would be in the adjuvant setting. So after their surgery, especially if they have stage 3 disease, what we know is that by giving patients the specific combination of dabrafenib and trametinib for about a year, we've seen improvements in outcomes, meaning less cancer coming back. The other setting that we often use these drugs are in the advanced disease, which we describe it as sort of unresectable stage 3, so disease that hasn't spread to an organ but can't really be removed by the surgeon, or in patients with stage 4 metastatic disease where, we're not able to remove any of the cancer. And in those settings, we can use any of those combinations. So some of the patients here and some of the patients online have probably received these types of therapies. And so the question is, how well do they work in the adjuvant setting? So one thing that we look at is something called relapse-free survival. This is and what relapse-free survival is really describing is time without any signs or symptoms of melanoma, either any scans or imaging that we use to detect melanoma. So what we're looking here, this is a little complicated, but on the y-axis is the percentage of patients, and then on the x-axis going across is just time. And so this is from a study where patients either received dabrafenib trametinib after surgery, or they received a placebo. And what we're seeing here is after 3 years, about 60% of the patients that had dabrafenib or trametinib did not still were relapse-free, meaning their cancer didn't come back, compared to the patients that got placebo, which was about 40%. And if we extend that over about 10 years, about half of the patients that received the targeted therapy did not have a recurrence compared to about 32%. So about a third of the patients there that received placebo. So these drugs work fairly well. I mean, obviously, we'd love that number to be higher, but compared to the standard of care about 10 years ago, which was not to do really anything, a close to a 20% improvement is very meaningful for our patients. So in the advanced setting, we can talk a little bit more, and these are just numbers I'll explain a little bit more clearly, but we do see benefits as well. So when we talk about response rates, what we're talking about is major shrinkage of the tumor. So these are patients with disease that we can follow on scans. And when we look at the response, what we're looking for is actual shrinkage. So that response rate is fairly high, which is around 60 to 70%. And in the context of cancer, that's an outstanding number. And sometimes these responses are very quick. So patients that are started on these therapies, within days, they can start feeling relief from their cancer, and we can start seeing changes as well. But the issue with these therapies is that they work really well in the initial phase, but how long do they work? And so when we talk about something called median PFS, basically what we're saying is how long were they on therapy before the cancer started to grow again? And you can see here that the median PFS is only about a year. So essentially, if you started therapy for your advanced melanoma, in about 50% of the patients, their cancer started to grow a year later. And in terms of overall survival, meaning basically how many patients, how long did you live after you started the therapy, that ranged somewhere between 2 to 3 years. And also on the flip side, which we'll also talk a little bit more about half of the patients did have some sort of side effect that was serious that they had to be managed with. So while they are effective treatments, there's a lot of caveats on how well they work and sort of how patients manage the toxicities of these treatments. So for patients that come to my clinic, they either were diagnosed with a stage 4 melanoma or advanced melanoma, and they have a BRAF mutation. Oftentimes we have a conversation about what type of therapy to start. And we'll talk a little bit more about immunotherapy, but generally what we say is there's two options. One is to start with immunotherapy or targeted therapy towards their BRAF mutation. And so I'll say that some patients do benefit from targeted therapy first. Like I mentioned, these treatments work really quickly. They have a high response rate, so we kind of know what's going to happen to the patients. And in the clinical setting, what that might look like is, a patient that is in the hospital, is really sick, and we need to start something quickly because, they're not going to make it out of the hospital unless we start something. Or they have disease in multiple areas, and we're just worried that by giving immunotherapy, which sometimes does take a little longer to work, we may run into problems if the cancer does not respond quickly. The other instance where we sometimes will start targeted therapy first are obviously for patients that can't get immunotherapy. So in that context, I'm talking about patients with perhaps an organ transplant, where we worry that by giving immunotherapy, they may go into transplant rejection, or if they have a serious autoimmune disease where the risk of them having a relapse or a flare of their autoimmune disease could be life-threatening. To help us answer that question for not those patients in that population, there was a couple trials, but here in the United States, there was a trial called DreamSeq. And so this trial was really pivotal in helping to answer part of that question. So in that trial, patients with BRAF mutations were enrolled. They've never received any sort of therapy. And so they were randomized, meaning a coin was flipped, and one group, well, I'll call group A, got immunotherapy first. And in this case, it was a combination of two drugs, ipilimumab and nivolumab. And they continued that drug until they had progression. And at the point of progression, they were switched to the targeted therapy. So they got one of the targeted therapies, BRAF and MEK. In group B, they received the opposite sequence. So they were started on dabrafenib and trametinib first, and at the sign of progression, they were switched to the combination immunotherapy. And so what the investigators of the study found was that group A, the group that received the immunotherapy combination first, had a significantly improved survival at 2 years compared to the group that just got targeted therapy first and then immunotherapy. And what that looks like at 2 years was about 72% of the patients that got immunotherapy first, compared to 52%, so 20% improvement for those that got targeted therapy first. So that's sort of answered or settled a little bit of that question. And the bottom line is that most patients that we see, we offer immunotherapy first rather than targeted therapy, despite all the benefits I had mentioned. Now I'm going to shift gears a little bit and sort of talk about, now that you've seen your doctor and they've recommended that you start a BRAF-MEK inhibitor, you may be doing well in terms of the tumor responding and you're seeing your scan shrink, but you're probably having some sort of side effects. Like I mentioned, about half of the patients have serious side effects, and then more than half, almost 90% plus, have some sort of side effects that they're dealing with. I'll touch upon a few of these today. So the most common side effects that we see that patients talk about are fever and pyrexia, fatigue. We do see quite a few skin toxicities. We see GI or gastrointestinal side effects, including nausea, vomiting, and diarrhea. And many of our patients complain of joint and muscle pain. There are some rare but serious side effects we also mention to patients when we start these medications. One is called cardiomyopathy, which we'll talk a little bit more. And there's also ocular toxicities. Both these side effects are related to the MEK inhibitor. So in general, we have to monitor for both since we give these in combination. So fever and pyrexia have been one of the more challenging side effects that patients know when they're on these therapies, particularly dabrafenib and trametinib. And it seems to be that the dabrafenib drives a lot of the fever. So we always recommend that patients have a thermometer ready. These symptoms can occur the same day that they start or within a few days. If you do develop a fever, depending on how high it is, we'll recommend that you hold the medication. Oftentimes that is enough for the fever to abate. In about 24 hours, the fever will you'll be fever-free, and then we'll have you talk about whether we should resume the therapy or make some adjustments. At the same time, most patients will recommend starting Tylenol or acetaminophen to help lower the fever, and or ibuprofen to help with that as well. In those cases, typically, we see pretty high fevers, sometimes over 102, even sometimes over 104, where patients start these therapies, Tylenol, they're on the Motrin, but the fevers don't go down, even when they're on it around the clock. And in those cases, sometimes we'll have to start something like a low-dose corticosteroids, typically prednisone, to help get that fever down. So really the goal when you do have fever is to obviously be fever-free. And there are different strategies in terms of how we can manage that. For me, and this is different if you ask different medical oncologists, for me, I try to keep the patient on the highest dose that they can tolerate and try to give them the Tylenol, sometimes around the clock, interspersed with ibuprofen to keep that fever away as much as possible. And if that doesn't work, oftentimes I'll just go to the prednisone. And the reason for that is, we feel or we think that, being on the highest dose can provide the best results. But at the same time, we can't have patients be miserable and having fevers every day. That's just not, tolerable at all. So in those points, we will talk about a dose reduction. And in some patients, what we've seen is sort of a pattern where they're on the pills and they're doing fine for 4 or 5 days, but then on day 6, the fever hits. They have these significant side effects. That's when we sometimes will tell them to just take a break, be off the medication for 2 or 3 days, and then what ends up happening is that sometimes they're on the medication during the weekdays, and then on the weekends they take a break, and they kind of go through this cycle where they need a drug-free period to kind of continue the medication. And that seems to be a good strategy because, you may not need constant inhibition of that pathway to achieve a benefit. Dr. Gale did an excellent sort of presentation about some of the skin toxicities, and I won't go over it too much, but in combination, I'll just say the BRAF-MEK inhibitors have luckily produced less skin side effects compared to the BRAF inhibitors alone. Historically, what we saw when these drugs were sort of discovered in sequence was that the BRAF inhibitors, patients got tons of side effects. They got new skin cancers. And then when we added the MEK inhibitors, the trials seemed to show that the MEK inhibitors canceled out some of those skin toxicities, which is actually a huge benefit for the patients. And there's a biological reason for that, but basically it shut off one of the pathways that led to more of these skin toxicities. So the most common ones we see, like Dr. Gill mentioned, is sort of an acneiform rash. We also see itchiness, dry skin, photosensitivity, and folliculitis. And I think the most important thing is, have your patients or have the patients see their dermatologist sometimes to help manage some of these significant side effects. Also talk a little bit about cardiomyopathy. And what that really means is sort of weakening of the heart muscle so that your heart doesn't pump as good. Some people call this something like heart failure. But what we're seeing is sort of what we call a MEK inhibitor class effect. So it's not the brand of the MEK drug. It's all the MEK inhibitors do this. And so that's why for all of our patients, we recommend getting a baseline echocardiogram to check something called the EF or ejection fraction. And all that is really saying is how well is your heart pumping? And we usually get a number, and anything over 50%, we consider normal. And then when you're going through treatment, we will regularly check your heart for with an echocardiogram, or if you're symptomatic, we'll definitely make sure that we check your echocardiogram to make sure that there's not a drop in the ejection fraction, because that would suggest that the heart is weakening. It's not pumping as well. And when I say symptomatic, typically patients will have symptoms of heart failure, like swelling in their legs, shortness of breath. Sometimes they'll have chest pain. Sometimes they may even have changes on their EKG to suggest that their heart is not working as well. This is an uncommon side effect, so luckily we're not seeing this across the board. But, this is something that we want to avoid as much as possible. The good news is that most patients have had resolution after stopping therapy. And oftentimes if a patient has, a history of heart failure or other, things like coronary artery disease or hypertension, we'll send our patients to our cardio-oncologist that will see the patients as well and sort of maximize their heart functions just in case something like this were to happen. Lastly, I want to touch upon a fairly rare, but something I've been seeing a little bit more often in some are sort of ocular toxicities. So essentially, effects on the eye, and this can range quite a bit. So for some of our patients, we recommend either regular visits or if they're symptomatic. I will say it is hard to get into an ophthalmologist, so sometimes we'll have their optometrist see them if there's any serious issues first and try to get them into an ophthalmologist quickly if we can. Most mild side effects include things like dry eyes or conjunctivitis, and we can treat that with just, over-the-counter eye drops or, topical steroid eye drops as well. Some patients develop something called uveitis, and that can present itself as just kind of pain in the eyes. And if severe, will lead to us having to discontinue the drug and even using not only topical steroids, but oral steroids to kind of calm that inflammation down. Luckily, that's not common, but something that, we have to watch out for as well, because it is a unique side effect that only occurs with the MEK inhibitors. And lastly, I'll talk a little bit about retinopathy. And so, the retina is in the back of the eye. It helps us see things, obviously. And what happens with patients that develop retinopathy is that they can develop a little swelling in that area. And this is a MEK-dependent class effect, meaning the MEK inhibitor is causing these symptoms. And what that might look like to a patient is something like blurry vision. Colors may look different, shadows may appear, and they may have a lot of light sensitivity as well. And so the typical story that I had recently too is that patients will start out on the drug. They'll take 1 or 2 doses. They'll call me back in a panic the next day and say, "Doc, I can't see anymore. Something's going on." Obviously, we're very concerned about it as well. They stop taking the drug, and their vision, usually comes back fairly quickly within half a day or a day or so. We'll get these patients in to see our retina specialist, and they help us to diagnose if the blurry vision is related to the MEK inhibitor itself. What to do next is always sometimes challenging, because what we typically recommend, depending on how serious it is for them to just resume the drug at full dose. And a lot of patients are very resistant against that idea because they don't want to have blurry vision. But for some of our patients, what we've seen is that their body sort of adapts to that, and the retinopathy sort of goes away after they continue the drug. So for some patients, this can resolve spontaneously after stopping the drug for a day or so, and then we're able to continue the MEK inhibitor. That is actually the conclusion of our talk. There are, the summary of this is that BRAF-MEK inhibitors are great drugs. We use them quite a bit. They do have their place in therapy. Immunotherapy is obviously very important, but these new drugs certainly help a lot of our patients. We still typically use immunotherapy first if you have a BRAF mutation, but if you can't get immunotherapy, these are excellent drugs to use. Unlike immunotherapy and their side effects, which Dr. Johnson will get into a little bit more, most of these side effects are sort of unique. The nice thing that I tell patients too is that if they do develop a side effect, because these are pills, they generally can just stop the medication, and most of these side effects will kind of go away on their own. Whereas, immunotherapy, the mechanism of those toxicities are different. This allows us to kind of make modifications on the treatment and hopefully get you through the therapy. It's really just sort of finding the sweet spot.